Hi everyone. So today's video we're going to be talking about cardiogenic shock. And if you enjoyed this video, make sure to subscribe to the channel and give it a thumbs up. We post all nursing content to help you guys get through nursing school and better understand the concepts that you will need to know for NCLEX and your nursing exams. So this video is on cardiogenic shock. Let's get into it. So what is cardiogenic shock? It is a condition of diminished cardiac output that severely impairs cardiac perfusion. It reflects severe left-sided heart failure. The pathophysiology is the inability to contract when the myocardium can't contract sufficiently to maintain adequate cardiac output. The stroke volume decreases and the heart can't eject an adequate volume of blood with each contraction. This can lead to pulmonary congestion. This is when the blood backs up behind the weakened left ventricle, and it includes preload and causes pulmonary congestion. Compensation is, in addition to compensating for the drop of stroke volume, the heart rate increases in an attempt to maintain cardiac output, which leads to a diminished stroke volume, which is as a result of the diminished stroke volume, coronary artery perfusion and collateral blood flow is decreased, which increases the workload. All of the mechanisms, including the heart's workload and enhanced left-sided heart failure. So the end result is that the myocardial hypoxia, which further decreases cardiac output and triggers a compensatory mechanism to prevent decompensation and death. So classification, there is coronary and non-coronary. So coronary is patients with acute MIs, and non-coronary is conditions that stress the myocardium as a result of conditions that result in an ineffective myocardial functioning. So statistics and incidences. So cardiac shock occurs as a serious complication in 5 to 10% of patients who are hospitalized with acute myocardial infarction. Historically, mortality of cardiogenic shock has been 80 to 90%. That is so high, but recently studies have indicated that it has dropped to between 56 and 67 due to advert thrombolytics, improved interventional procedures, and better therapies. Incidences of cardiogenic shock is more common in men than women because of their higher incidence of coronary artery disease. So the causes of cardiogenic shock is myocardial infarction. So regardless of the underlying cause, this is when the left ventricle dysfunction sets in motion a series of compensatory mechanisms that attempt to increase cardiac output, but later on leads to deterioration. Myocardial ischemia, which the compensatory mechanism may initially stabilize the patient, but later on would cause deterioration with the rising demands of oxygen on the already compromised myocardium. In end-stage cardiomyopathy, the inability of the heart to pump enough blood for the system causes cardiogenic shock. So clinical manifestations, you may see clammy skin. The patient will have cool, clammy skin as the blood cannot circulate properly to the peripheries. You may see a decreased systolic blood pressure, which can decrease to 30 points below their normal baseline. You may see tachycardia because the heart is pumping faster than normal to compensate for the decreased output all over the body. You may see rapid respirations. These will be rapid, shallow respirations because there's not enough oxygen circulating in the body. You may see oliguria. So this is when there's a decreased output of urine, which will be less than 20 mLs per hour. You may see mental confusion because of insufficient oxygen to the brain. And you may see cyanosis because, again, insufficient oxygen is being distributed all over the body. So as a nurse, our assessment and diagnostic findings, so we are going to use auscultation to detect gallop rhythms, faint heart sounds, if shock results from a rupture of the ventricular septum or papillary muscles, a holeosystolic murmur may be present. Pulmonary artery pressure is something else that we're going to look at, which may show if there is an increase in pulmonary artery pressure, it will reflect a rise in the left ventricle, and diastolic pressure and an increased resistance to the afterload. We may also use arterial pressure monitoring. This is an invasive arterial pressure monitoring which can indicate hypotension due to impaired ventricular ejection. We may look at ABG analysis. So these are arterial blood gas analysis, which may show metabolic acidosis or hypoxia. We may look at an electrocardiogram to show the evidence of an acute MI, ischemia, or ventricular aneurysm. We may look at an echocardiogram, which can determine left ventricular function and reveal valvular abnormalities. And we may look at enzyme levels, such as lactic dehydrogenase, creatinine kinase, aspartame aminotransferase, and alanine aminotransferase, which can all confirm an MI. So the medical management of a patient dealing with cardiogenic shock is going to be oxygen to minimize damage to muscles and organs. They may have an angioplasty and stunting, so this is a catheters inserted into the blocked artery to open it up. They may have a balloon pump, which is inserted into the aorta to help blood flow and reduce the workload of the heart. They may be given some pain control if they're experiencing chest pain. There may be some IV morphine for pain relief. We may also do some hemodynamic monitoring through an arterial line, which can help to give an accurate and continuous monitor of the blood pressure. Also provides a port for which can obtain frequent arterial blood samples. And fluid management. So we may administer some fluids, but they must be monitored closely to detect signs of fluid overload. So the pharmacological management for these patients may include IV dopamine, which is a vasopressor. It increases cardiac output, blood pressure, and renal blood flow. They may be given some IV dobutamine, which is an agent that may increase myocardial contractility. They may also be given some norepinephrine, which is a more potent vasoconstrictor that is taken, that they'll give when is necessary. And IV nitroprusside, which is a vasodilator that may be used with a vasopressor to further improve cardiac output by decreasing peripheral vascular resistance and reducing preload. So the surgical management will include a mechanical assisted device that attempts to improve the coronary artery perfusion and decrease cardiac workload through an inflatable balloon pump, which is surgically inserted through the femoral artery into the descending thoracic aorta. And this is called an intra-aortic balloon pump. And as you can see, during diastolic, the balloon inflates, and during systole, the balloon deflates. So our nursing assessment is going to include vital signs. We'll be assessing all of the vital signs, including blood pressure. It's most important. We'll be looking at and assessing fluid overload. So the ventricles of the heart cannot fully eject the volume of blood at systole. So fluid may accumulate in the lungs. You want to be watching for that. So our nursing diagnoses could include things like decreased cardiac output related to changes in myocardial contractility, impaired gas exchange related to changes in alveolar and capillary membrane, excess fluid volume related to decrease in renal organ perfusion, increased sodium and water hydrostatic pressure, increased or decreased plasma protein, ineffective tissue perfusion related to reduction of blood flow, acute pain related to ischemic tissue secondary to blockage or narrowing of coronary arteries, and activity tolerance related to imbalance between oxygen supply and needs. All right, so nursing care planning and goals. So when we are caring for these patients, we want to prevent reoccurrence of cardiogenic shock. We want to monitor their hemodynamic status. We want to administer medications and intravenous fluids. But remember to be monitoring those if they're getting intravenous fluids, we need to monitor for fluid overload and maintain an intra-aortic balloon counterpulsation if they do have one of those inserted. So our nursing interventions. We want to prevent the reoccurrence, so we want to identify patients at risk early and promote adequate oxygenation of the heart muscles. Decreasing cardiac workload can prevent this cardiogenic shock. We want to look at the hemodynamic status so we can have arterial lines and electrocardiogram monitoring equipment. We want to make sure the equipment is well maintained and functioning. We want to monitor for the changes in hemodynamic, cardiac, and pulmonary status and laboratory values, making sure they're all documented. We want to be assessing those adventitious breath sounds, changes in cardiac rhythm, and other abnormal physical assessment findings should be reported immediately. We want to also use fluids, so IV infusions have to be observed closely because of tissue necrosis, and sloughing off can occur with vasopressing medications if they infiltrate in the tissues. So if a patient is on an IV with a vasopressor, you're looking for infiltration. So is the arm or wherever it is swollen? Is it red? Is it painful? Those are all things you want to be looking for. And we also want to monitor the intake and output. A patient's output is really going to help to identify their renal status. So we just want to make sure, that the patient is having an adequate output of urine, but also noting their intake, make sure they're not holding on to water. Also, we want to be maintaining that intra-aortic balloon device. The nurse makes ongoing timing adjustments of the balloon pump to maximize its effectiveness by synchronizing it with the cardiac cycle. We want to enhance safety and comfort, so administering of medications to relieve chest pain, preventing infection at the arterial and venous line insertion sites. We want to protect the skin and monitor respiratory and renal functions to help enhance patient comfort and safety. Arterial blood gases, we want to monitor values to measure oxygenation and detect acidosis from poor tissue perfusion. And we also want to use positioning. If a patient has that intra-aortic balloon pump, we want to reposition them and perform passive range of motion exercises to prevent skin breakdown, but we don't want to flex the patient's ballooned leg at the hip because this may displace or fracture the catheter, because remember, they're going in through that femoral artery. So just things to keep in mind. So our evaluation. We want to prevent reoccurrence of the cardiogenic shock. We want to monitor that hemodynamic status. We want to administer the meds and, again, maintain that balloon pump. All right, so discharge and home care. We want to control hypertension. We want to teach the patients about exercise, managing stress, maintain a healthy weight, and limit salt and alcohol intakes. We also want to teach them to avoid smoking because the risk of stroke is the same for smokers and even non-smokers after you stop smoking. Smoking is just not good for your heart health in general. We want to teach them to maintain a healthy weight. So losing extra pounds can be helpful in lowering cholesterol and blood pressure. We want to promote eating a good diet that is eating less saturated fat and cholesterol to reduce heart disease. And we want to promote exercise daily to lower blood pressure, increase high density lipoproteins, so that's that good cholesterol, and improve overall health in the blood vessels and heart. All right, so our documentation. So we want to do a baseline and subsequent findings for the individual, because we want to be able to see, is the blood pressure going up? Is it going down? Is the heart rate going up, going down? So you want the baseline, and you want further documentation. You want to do this again with heart and breath sounds, looking at ECG patterns, the presence and strength of peripheral pulses, skin and tissue status, renal output, and their mental status. We also want to document respiration rate, character of breath sounds, frequency, any secretions, any presence of cyanosis, laboratory findings, and again, mental status. Conditions that may interfere with the oxygen supply, we want to document. Any conditions contributing to fluid retention, we want to look at fluid balance, INOs, our pulses, blood pressures. We want to document the client's pain and their description of the pain, what they describe as the acceptable level of pain, and we want to document pain meds used. And then once you give a pain medication, you also want to document the patient's response to those medications. So did they find relief? So we want to look at baseline and current findings. Again, these are the same thing: heart and breath sounds, EKGs, and all right. And then we also want to include in our documentation our plan of care, our teaching plan, the client's response to our interventions and actions performed, status and deposition at discharge. Are they excited to go home? Are they hopeful? Are they scared? How are they feeling? Attainment or progress towards desired goals, and any modifications made to the plan of care. All right, so that is the information on cardiogenic shock. If you guys found this helpful, make sure to subscribe to the channel and give this video a thumbs up. And we have a lot more videos about things that you need to know in nursing school. So I hope you found this helpful, and I will see you soon. Thank you. Bye.